Hello, welcome to the EKG Guy and welcome to the EKG of the Week. I hope you're having a great week and I'm glad you could join us. So this week's case is a 61-year-old female with a history of hypertension and COPD. She presents with worsening shortness of breath. Her presenting EKG is shown here. Now before we get started, let's review the approach we've been using to interpret EKGs. So notice we have the patient's clinical presentation and then the EKG below it. On the right side of the screen, we have a list that we'll go through before making our final interpretation. First, we have the regularity of the rhythm, meaning are we dealing with a regular or irregular rhythm? And then we'll decide if we have an irregular rhythm, is it regularly irregular or irregularly irregular? Next, we have the heart rate, in which we simply want to determine the rate of the rhythm. Then we have the rhythm origin, that is, where is the rhythm actually originating from within the heart? And then we'll look at and determine the ventricular or Qrs Access, which could help us with our differential diagnosis. Then there's the atrioventricular, and intraventricular conduction, looking at if conduction is normal or abnormal in any area of the heart. Then we have the waveforms, which we'll look at all the waves, segments, and intervals. And lastly, anything else, meaning is there anything else that we've missed or still need to mention, such as abnormal R wave progression or transitional zone in all the precordial leads. After that, we'll use all the information we've gathered to make a final interpretation of the EKG. Now I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll go through it together. So our 61-year-old female with a history of hypertension and COPD presents with worsening shortness of breath in this EKG. So let's go through it. Now first, what is the regularity of this rhythm? Well, on first impression, you probably notice that this appears quite regular. In fact, this is a regular rhythm, okay? So with our regularity, we will write regular, okay? And how do we know if a rhythm is regular or not, okay? One of the easiest ways is to look at the R waves, okay? Because they're the most prominent. So if we look down here at V5 in this rhythm strip, notice this is an R wave, and then we have an R wave here. So this interval between each R wave is called the R to R interval, okay? And when looking at regularity, we want the R to R intervals to be equal throughout, okay? So meaning the next R to R interval from this R wave to this one should have the similar interval or duration between these two, okay? And if you went throughout the EKG, you would see that all of these R to R intervals are the same throughout, okay? So that's one thing, you can use your calipers to determine that, okay? So you can pause the video and try to do that yourself, but this is a regular interval or regular rhythm. So what do you get for the heart rate? Well, there's a couple ways we can calculate it here because we have a regular rhythm, okay? So one way we could do it is by counting the number of complexes going across the whole EKG and then multiplying that by 6. So why can we do that? Well, we have to know that the standard EKG represents 10 seconds in duration, okay? So if you multiply 10 seconds by 6, you get 60 seconds, which is 1 minute. All right, so if you count the number of complexes going across, multiply that by 6, you can get an estimate of the rate, okay? So we'll determine the ventricular rate, meaning we'll count the number of QRS complexes going across and multiply that by 6 to get an estimate. So let's do that here, okay? So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, and 20. Okay, so 20, and maybe here's the 21st one showing up there. Okay, so let's say 20. So what we would do here is 20 times 6 gives us a rate of about 120 beats per minute. Okay, now because we said we're dealing with a regular rhythm, we can also do it another way. Okay, so you want to find an R wave that falls on one of the thick lines. Okay, so let's do that here. We'll erase some of this. So we'll find an R wave and notice that this complex here falls pretty close to that thick line. And we're going to find the next R wave, which would be this one, and count the number of thick lines between it. So we have 1, 2, 3. Okay, so it's right between 2 and 3. Okay, so if we say 300 over 2 is 150, all right, and then 300 over 3 is 100, okay, meaning that our rate is somewhere between 100 and 150, okay, so about 125 beats per minute. Now another way you could do it with some of these faster rhythms is by taking the number and counting the number of small boxes between the R to R interval, okay, so we found this was an R wave and here's the next one, okay, so you'd count the number of small boxes from here up until here, okay, and what you would do is then 1500, and you would divide it by the number of small boxes. In this case it's 12, okay, so 1500 over 12 is 125 beats per minute. Okay, so very close to what we had with 120, the 125 here, and then this case. Now the actual rate by the machine was calculated at 125 beats per minute. Okay, so we are very close with all of these, and you can see that that last approach is the most specific one. Okay, so now to the rhythm origin. Well, we have narrow QRS complexes, so it must be supraventricular in origin, that is originating from above the ventricles. We can also make out clear, defined, similar shaped P waves in each lead. So we have to ask ourselves, are we dealing with sinus rhythm? So let's see here, okay? Now with sinus rhythm, you have to know that you want to see upright P waves in the left lateral and inferior lead. So 1, 2, AVF, V4, V5, and V6, okay? So let's just ask ourselves, why is that the case, okay? So we want to see, we said upright P waves, okay, in 1, 2, AVF, V4, V5, and V6. So if you imagine we have our heart here, okay, this being our right atrium, our left atrium, right ventricle and left ventricle. Our sinus node sits up here in the right atrium near our superior vena cava. We have our internodal pathways that come to our AV node with a His bundle that splits into the right bundle branch, and then we have the left bundle branch that splits into the left anterior and left posterior fascicles. Now both the right bundle branch and ththese fascicles on the left side then go to our Purkinje fibers that innervate the cardiomyocytes. Okay, so if you notice, we have our sinus node in our right atrium, okay? And when we're talking about sinus rhythm, we mean that it's coming from this area, okay? The rhythm's originating there and heading in this direction, okay? So if you were to superimpose our right atrium on top of here, this being our sinus node, you can see that it would head in this direction, okay? So when we look at the P wave axis or the rhythm origin, we want the P wave axis to be between 0 degrees, which is here, and positive 75 degrees, okay? Now, if you ask where our leads are placed, well, this is where the positive end of lead 1 is placed. This is the AVF, okay? Then we have 2 here. And then in our horizontal plane, we have V4, V5, and V6, okay? And because that we have the electrical axis of the P wave heading in that direction, that's why we see upright P waves in those leads, okay? They're a positive upright, and they're going away from lead AVR, which is placed here. Therefore, we'll see negative P waves in AVR, okay? So let's take a look at the EKG here. So here's lead 1 and lead 2, and you can see these P waves are upright here, okay? And the same thing in lead 1. If you take a look at AVF, which is this one here, you can see that our P waves are upright as well, okay? And then if we go to those lateral leads, we can see in V4, V5, and V6, so upright P waves. So here's V4, V5, and V6, upright P waves here. Same thing in V6, all right? And then AVR, which is this one here, we said we would see negative or inverted P waves as we do here, okay? Hard to make out, but there's one there, okay, and another one there, okay? So we have the right P wave morphology, and we saw those upright P waves in the inverted one in AVR. They all have similar morphology, meaning if you look through each one, they all look the same, okay? They're not originating from ectopic foci within the atria. And remember, we want to have, with sinus rhythm, a P wave coming before each QRS complex, okay? So each P wave comes before it, and we see that here, and there should be one P wave for every QRS complex, okay? So what we mean here, just erase that so you can see this. So this is a P wave, this is a QRS complex, okay? P wave, QRS complex, P wave, QRS complex. Okay, and there's one P wave for each QRS complex. So because we met all that criteria, we can in fact say that we are dealing with a rhythm that originates from the sinus node. Okay, so let's look at the ventricular or QRS axis now. You should have gotten a normal ventricular axis. Okay, the value here was actually positive 59 degrees. Okay, so it's normal in positive 59 degrees. Okay, so how do we know that? So again, we'll erase this so you can see it. In this case, the electrical axis is where, when we talk about ventricular axis, that's where the mean axis in the ventricle is heading towards, okay? Remember, the left ventricle is the biggest portion of the heart, the biggest ventricle, so it will oftentimes take up in where the electrical axis will be heading to, okay? So if this is 0 degrees, we said this is the positive end of lead 1, this is positive 90 degrees, where the positive end of AVF sits, okay? And then we have plus or minus 180 degrees, and this would be negative 90 degrees, okay? Now we said that the axis was positive 59 degrees, meaning that it would come somewhere in this region, okay? Now remember, normal access in adults is between negative 30 degrees and about positive 105 degrees. Okay, so all this region here is considered normal. Then we would have that right axis shift over in this region, right axis deviation and left axis deviation. Okay, and then this would be more of an extreme axis deviation, sometimes referred to as no man's land. Okay, so let's see why we got this positive 59 degrees. Okay, so we want to look at lead 1. So we erase this here so you can see it. Okay, we'll first look at lead 1 and AVF. There's multiple ways you can do this. So lead 1 has these QRS complexes that are mostly positive. So we'll be heading towards the positive end of lead 1. Okay, then we'll take a look at AVF, and it's also positive and upright. Okay, meaning we're going towards the positive end of AVF, and our axis sits somewhere here, so we know that we're dealing with a normal axis. Okay, you can look at lead 2 to further define your axis, but because we have already a normal axis, we won't go any further at this point. Okay, so normal ventricular axis at positive 59 degrees. Now, how about atrial conduction? Well, typically we'll look at leads 2 and V1 for P wave or atrial abnormalities, as they appear most evident in those leads. When in leads 2 and V1, okay, we don't reach the P wave amplitude or duration for right or left atrial enlargement. Normal P wave duration should be less than 110 milliseconds, as we see here. So we don't have any atrial conduction abnormalities. Okay, so nothing here in this case. How about atrioventricular or AV conduction? Well, here we're looking for any conduction delays as the impulse travels between the atrium ventricles. Because the majority of the PR interval represents AV nodal conduction, we tend to look there. The normal PR interval in adults is between 120 and 200 milliseconds, or 3 to 5 small boxes we're dealing with in adults here. Okay, here the PR interval was within normal limits, and the one that was actually measured was 160 milliseconds. Okay, so the PR interval, just so you're aware, was 160 milliseconds. Okay, and that is normal. So we don't have any AV conduction abnormalities. Now, just so you're aware, when we talk about the PR interval, draw this out here so you can see, this being a P wave, QRS complex, and a T wave, the PR interval includes the P wave, so it starts at the beginning of the P wave and goes up to the beginning of our QRS complex. Okay, so that's what we mean by the PR interval. When we talk about the PR segment, that's from the end of the P wave up until the beginning of our QRS complex. Okay, so in this case we had a normal PR interval at 160 milliseconds. Okay, next we have to look at intraventricular or IV conduction. Here we look at the duration of the QRS complexes. Normal QRS duration is often between 70 and 110 milliseconds, or about 2 to 3 small boxes. The main thing here we're checking for is with intraventricular conduction is whether or not the QRS interval is prolonged. We can see narrow QRS complexes that appear within normal limits in this case. In fact, the QRS duration here was 84 milliseconds, so that helps to confirm that IV conduction is normal. Okay, so in this case, we have an QRS interval that was 84 milliseconds. Okay, so this was also normal, so no intraventricular conduction delays. Now, how about the waveforms? Well, we said the P waves were normal. Okay, there are no pathological Q waves or QS complexes that would suggest a prior infarct. We see normal T waves that are asymmetric with a slow upstroke and steeper downslope. The PR and ST segments do not appear to be significantly depressed or elevated anywhere. The PR and QRS intervals we said were within normal limits. The QRS amplitude does not seem abnormally increased or decreased throughout the EKG. And lastly, the waveforms, we have the QTC interval is normal here. Remember that normal QTC interval in males is less than 440 milliseconds, and in females it's less than 460 milliseconds. Now, our patient here, we said, is a female, okay, and the QTC interval in this case was calculated at 447 milliseconds. So in this case, I'll write it here, 447 milliseconds. Remember, females, the upper limit is 460, so we are within normal limits. So overall, there are no major waveform abnormalities, okay. All right, so is there anything else we're missing in this EKG? Well, how about the R wave progression in the precordial leads? Normally, the R wave amplitude should progressively increase from leads V1 to V5. In this case, it seems pretty normal with a steady progression from V2 to V5, although there is a big jump in R wave amplitude from V1 to V2, suggesting stronger anterior forces, okay? Now, anyways, we can generally say this is pretty normal and not something to be too concerned with. Remember, R wave progression is highly dependent on lead placement, okay? And what we're talking about here with this R wave progression is you can see these small R waves that are a little difficult to see, but they are present there, okay, in V1, and then all of a sudden you see this bigger leap in the R wave amplitude, okay, but from V2 to V5 we see an increase that is progressing normally with the R wave amplitude. So in this case, maybe V1 wasn't placed properly, or there's stronger anterior forces that this would suggest. Now we have to look at the transitional zone and the precordial leads, okay? And in this case, it appears to occur between V3 and V4. The transitional zone is simply the precordial lead where the QRS transitions from being mostly negative to mostly positive, with the actual transition area occurring where the QRS complex is isoelectric. Normally, the transition zone occurs between V3 and V4. If it occurs earlier than V3, we call this a counterclockwise rotation or early transition. And then if it occurs after V4, we call that a clockwise rotation or late transition. Okay. Now, because the transition occurs between V3 and V4, in this case, we call that a normal transition. Okay. Now, just so you're aware what we mean by this transition zone. Okay, again, we're looking at the precordial leads. Remember, the precordial leads are on this side from V1 to V6, okay? So we're looking in the horizontal plane, and the normal transition should be between V3 and V4, okay? And we mean when a complex goes from being mostly negative to being mostly positive, okay? So if you imagine here's in V1, all right, V2, V3, V4, V5, and V6, we can see V1 is mostly negative, okay? So we'll write negative. And then if we look at V2, we can see here is actually, if you were to count those, it's still mostly negative. And the same thing holds true for V3, okay? In which case, we're looking for the amplitude of this S wave, okay, versus that of the R wave, okay? And it's still slightly about 1 millimeter more negative in V3. And then we start to see a change where the R wave here is greater than the S wave there, okay? So it starts to become positive. Now where it goes from negative to positive is in this zone between V3 and V4, which we said was normal. So that's why we have a normal transition, okay? Now, one thing I want you to keep in mind with the transitional zone, like R wave progression, it is highly dependent on lead placement, which is, again, an imperfect science. So in general, we'll say we have normal R wave progression, okay? Maybe you can say this is slightly abnormal in V1, but generally, let's say it's normal in this case, as well as the transitional zone, okay? Not something to be too concerned with, because otherwise we have a pretty normal EKG, okay? So anyways, what's our final interpretation? Well, we have a regular rhythm with sinus origin, and we said the rate is 125 beats per minute, suggesting sinus tachycardia, okay? The ventricular access we said was normal. There are no atrioventricular or intraventricular conduction abnormalities. We said there's no major waveform abnormalities as well. We saw generally a normal R wave progression in the precordial leads with a normal transition between V3 and V4, and when compared to a previous EKG that's not shown here, there were no significant changes found. So you always want to make sure you're looking back at the old EKG if available to look for any changes between the most recent and past recordings. Okay, so let's write our final interpretation here. Erase this. So our final interpretation is sinus tachycardia. Okay, what does that mean? It means that we have a rhythm originating from our sinus node in that it's tachycardia, meaning it's fast, above 100 beats per minute. In this case, it was 125. Okay, and then when we compare it to the old EKG, so when compared to old ECG, okay, which you always want to do, there were no significant changes, okay? So in conclusion, our 61-year-old female with a history of hypertension and COPD that presents with worsening shortness of breath has an EKG showing sinus tachycardia. Well, that's the end of this week's EKG of the Week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you can help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos. There's also a community of over 150,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. If you need a crash course on EKGs, we launched our new EKG course. Check the link below if you're interested. The original cost is around $100 $150, and I believe I made it less than $20 for a limited time. I may be biased, but after reading nearly every EKG textbook on the market, I think this is by far the best EKG series to take you from the beginner level to a physician level. I've even included our pediatric lectures. Anyways, check it out for yourself. I think you'll really enjoy it, and a number of medical schools and hospitals are beginning to use it. If you are a part of an institution, please contact us because we're giving a limited number of schools and hospitals free access to provide feedback and improve our course. And in that case, you can get the course for free. So leave a comment below and get in touch with us. And of course, check out our brand new website, ekg.md, the premier EKG resource for medical professionals, where you can find more lessons and practice. That is www.ekg.md. Last but certainly not least, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. So let us know how we're doing. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.